Hello, everyone. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about aortic aneurysms. Now, we covered aortic dissections in our previous lecture, and today we're going to be focusing primarily on understanding how these differ from dissections, and then talking a bit about how we manage them in the acute setting. So, starting off nice and easy, what is an aneurysm and how is it different to a dissection? So, we talked about dissections being kind of a false lumen being created where you have blood pooling within it. That's often because we have initial damage to the tunica intima, which is the inner layer, and then that eventually creates room for blood to fill in that inner space. However, aneurysms are slightly different. Now, instead of there being a false lumen between one or two layers, you have all three layers expanding or dilating to a degree that they should not usually be at. And you can see for reference, here's a picture of a fusiform infrarenal aortic aneurysm, where you have all three layers actually dilated. It's not just the outer layer, it's all three of them. And the threshold we usually talk about is about 1.5 times its normal diameter. What are some important risk factors for aortic aneurysms? Well, smoking, old age, atherosclerosis, hypertension are all important risk factors. But going back to why this exactly happens, the exact etiology is unknown. However, what we suspect is going on is you have a long-term process where you have inflammation and degeneration of the connective tissues of each of those layers. Over time, they lose some of their elasticity and structural integrity. And with further atherosclerosis, hypercholesterolemia, and hypertension, that just adds on enough pressure to cause kind of a bursting out and a dilation of the vessel itself. Now, where does this usually happen? So we broadly classify aortic aneurysms as either being infrarenal or suprarenal in relation to its position with the renal arteries. Which is more common, infrarenal? How do they usually present? Well, different compared to aortic dissections, aneurysms are a bit different because unless they've ruptured, they often can be asymptomatic, which is why they're often picked up incidentally. It's also another reason why a ruptured aortic aneurysm is so dangerous and has a very, very high mortality rate of about 83% if outside a tertiary care hospital. It is because most of these patients will have no idea that they had anything wrong until the very last stage. Ruptured AAAs, as I mentioned, can present with lower back pain, a pulsatile abdominal mass, as well as bruise on auscultation because of that turbulent blood flow. So what investigations do we order and how do they compare? Ideally, we want to order an investigation which can actually show and visualize that aortic diameter, and the threshold we use is about 3 centimeters. For patients who are stable, our go-to investigation is usually an abdominal ultrasound. This is really good because it's easy to perform and can give us a good estimation of the aortic diameter. Also, because it's a dynamic investigation, you can actually see the blood flow and also look for any thrombosis within the vessel itself. CT angiography is another very good investigation. And well, you may ask yourself, well, when do I do a CT angiography if an abdominal ultrasound is so good? Well, obviously, if you can't do an ultrasound, that would be one circumstance. But the other one being, if you do intend to intervene, which would mostly be surgical intervention, it's very good at visualizing what the exact levels of the aneurysm are and how extensive is the actual aneurysm and what the exact shape of it is. So an ultrasound is really good for telling us the maximum diameter versus CT angiography, which provides a bit more extra information for those who might be undergoing surgery. So how do you treat them? So I guess straightforward, if the patient is symptomatic, which usually means that they have had a rupture, if they're hemodynamically unstable, all these patients will be rushed to the OR as an emergency and undergo open surgery. If a patient has a AAA that you pick up, however, is asymptomatic, then that raises a few questions. Well, do we operate? Do we observe? Which one do we do? And the question you should be asking yourself is the risk of surgery greater than the risk of rupture? And to determine this, we basically look at, obviously, there's surgical risk as a candidate for surgery, but also, more importantly, what the actual aortic diameter is. Now, as I mentioned, the cutoff is usually 3 centimeters, and the risk of a 3 centimeter aortic aneurysm rupturing is pretty low. However, the risk of a 7 centimeter one is pretty high. So as the size increases, your likelihood of performing elective surgery for them also increases. The cutoff where the risk of a rupture is greater than the risk of the surgery is often considered to be about 5.5 centimeters for most Australian centers, including Monash Health. Another thing that they look at is if you, let's say, have an aneurysm that's picked up on some other investigation, you might then have frequent reviews. Now, the frequency of the review depends on how large the aneurysm is. If it's about 4 centimeters, you usually go for a yearly review. And any rapid change, so if there's, let's say, an increase of more than 1 centimeter per year, that is considered relevant enough to require surgery, corrective surgery. So that's, I think, a good number to know. Anything else would obviously just receive yearly reviews and making sure that they still fit for surgery if needed. So what are our options when it comes to surgery? The one that we do electively is called an endovascular aneurysm repair, where we go in and we use a graft to basically redirect blood flow and prevent more pressure being applied on the aneurysm, which is only going to further dilate it. However, if there's been a rupture, we often need to take a more open approach, and this would require obviously an open surgical repair of the aneurysm. And often the risk of an open repair is much, much, much higher than that of an endovascular one. This is because they've already ruptured, and repairing a ruptured aorta is very, very hard to do. Some important complications you should know of an abdominal aortic aneurysm. Obviously, we talked about ruptures. We also need to know that they might be, they are at a higher risk of emboli. This is predominantly because, as you can imagine, with an outpouching, there's going to be turbulent blood flow in those regions, which is going to put you at a high risk of thromboembolic events. You can further have an aortic dissection because with these ballooned up areas, you have also weaknesses in those linings, including weaknesses in the tunica intima. With enough pressure, that can cause a dissection, which, as you can imagine, it is not pretty to have a dissection on top of an aneurysm. In terms of surgical complications, you can have ischemia of the gut or the kidneys, depending on where the aneurysm is. This is partly because with a surgical approach, you often clamp the aorta to be able to repair it sometimes. And if you have insufficient perfusion distal to the site of the aneurysm, that is often going to be the gut, based on the superior mesenteric artery and the inferior mesenteric artery, as well as the renal arteries, if it's suprarenal. You can also have infected endovascular grafts and grafts that leak, which, as you can imagine, is not pretty. And that's often going to require further corrective surgery. I hope that all made sense. That's all the information we had on aortic aneurysms. If you have any questions, please feel free to contact me on my email or through Facebook. And as always, please look after yourself and look after your loved ones. I'll see you guys in the next one.